Good evening, everyone. We've had a lot of activities last month. All of you are probably full of knowledge now. And this meeting, this meeting has to happen because by convention we have a monthly meeting. So this monthly meeting is hosted by Mamsi and Dr. Asmita, and I welcome you all to this meeting. And before we proceed with the clinical scenario, I would want Dr. Divya Pandey to give the report of the last month's activities. Over to you, Divya.
Thank you, ma'am. So I will be presenting the secretary report on behalf of Dr. Monica Gupta. This time I am Dr. Divya Pandey, Joint Secretary, Aogd. I'm now sharing my screen. Can you see my screen?
Not as yet. Not as yet. Yeah.
No?
No. Yes, now it's okay. Start, Divya.
Okay. So I'll be presenting the report for October-November 2021. So we started our month with the Aogd monthly clinical meeting at ESI Hospital, where wonderful cases were discussed at ESI Basai Darapur on 29th October. This was followed by online masterclass on management of cervical cancer, nuances and changing perspectives on 30th October by the Oncology Committee. It was followed by a CME on adolescent PCOS by Aogd Adolescent Health Committee along with IMA Outer West Branch of Delhi. It was a physical meeting. Then we started with our the most awaited event of Aogd, the 43rd annual Aogd conference, with the theme of strong will and quality skills promoting women's health. As you all know, it kick-started with the 8 pre-conference workshops starting on 11th of November. The first was on progress in fetal diagnosis and therapy by the Fetal Medicine and Genetics Subcommittee on 11th November. Then there was Care Bundle for Stillbirth, Making Every Baby Count by Safe Motherhood Committee on 12th November. We had another wonderful workshop on e-PICSEP by Aogd in collaboration with Foxy on 13th November, where we conducted quiz and research methodology was discussed. Then we had another quiz for adolescent health for the Yuva members by Aogd on 14th November amongst these workshops. When the quiz winners, the first, second and third prize was backed by Dr. Shivani Verma of VMMC and Safdarjung Hospital, Dr. Kanika Kalera of GTB Hospital and Dr. Vaishnavi Jairam of Maulana Azad Medical College, respectively. Then in continuation, we have the workshop on medico-legal concern in obstetrics and gynecology on 14th November by BAMC and LNJP Hospital. A to Z of PPH by Aogd Multidisciplinary Committee on 15th November by DDO Hospital. Then we had hyperandrogenism evidence-based methodology. This workshop was conducted by Reproductive Endocrinology Subcommittee on 16th November. And then there was another wonderful workshop dealing with myomas endoscopically by which was organized by Endoscopy Committee on 17th November. This was done by Fortis and Sir Gangaram Hospital. Then protocols and procedures for cervical cancer prevention video session. It was organized by Oncology Committee on 18th November. So after these pre-conference workshops, we had a tremendous response and we had over on an average 200 registrations per workshops. Then we started the 43rd annual Aogd annual conference on 19th, 20 and 21st, of which 19th was an offline event and was widely appreciated by one and all. These are the glimpses of the inaugural ceremony of the 43rd annual Aogd conference. We had as chief guest, we were proud to have Dr. P. Ashok Babu, who is the Joint Secretary of Reproductive Childhood MOHFW, along with the guest of honor. She was the Foxy President, Dr. S. Shanta Kumari. along with the different dignitaries. Then we released a ready reckoner for obstetric emergencies at the inaugural ceremony. Dr. Riva Tripathi ma'am was felicitated as Crusader of the AOGD for her outstanding contribution to AOGD. And Dr. S.N. Mukherjee rotating trophy went to All India Institute of Medical Sciences. Our conference proceedings were widely covered by the media, both online and offline, as you can see here. Then after this, there were 4 very nice post-conference workshops from 22nd to 25th of November. The first one was revisiting basic infertility practices by Infertility Committee on 22nd November, where a workshop manual was also released. Then we had another wonderful workshop, Fighting the Fright, Non-Hemorrhagic Maternal Collapse on 23rd of November, organized by GTB Hospital. Then we had Episiotomy and Obstetric Anal Sphincter Injury workshop by Urogyne Committee on 24th November, and Safe Abortion Values, Evidence and Respect by the Safe Motherhood Committee and Quality Improvement Committee on 25th of November. We got tremendous response during our conference, and we got over 470 registrations for the conference. And on an average, as I told you, per workshop, we had on an average 200 attendance, barring few where the attendance went up to 400, especially in infertility, endoscopy, and PPH workshop. This was not all. After the conference, we had our ECME on hyperglycemia in pregnancy, optimizing pregnancy outcome by Safe Motherhood Committee. Then yesterday only we had tubal corrective surgeries, the use of endoscopy by Endoscopy Committee, where wonderful videos were shown. So the forthcoming events are, there will be a PG forum on diabetes in pregnancy by LHMC on 20th December. There will be a masterclass by Endoscopy Committee. On 23rd December, a webinar by Oncology Committee and webinar on chronic pelvic pain on 30th December. Our next AOGD monthly meeting will be at Sir Gangaram Hospital on 31st December 2021. And I take the privilege to invite you all to the valedictory function for 43rd Annual AOGD Conference 2021 to be held tomorrow at Hotel Park, 6 p.m. onwards. And I humbly invite all of you to be there. Thank you very much. I now hand over to Dr. Ashmita ma'am for further proceedings.
Thank you, Dr. Divya. I think it's on. Am I audible? Am I visible?
Yes, ma'am, you are.
You to unmute here.
Yeah, you're audible. Asmita, you're audible.
I'm audible, na? Yeah.
And
So
visible.
on behalf of Department of Obstetrics and Gynae of Maulana Azad Medical College, I extend a very warm welcome to all the attendees and my seniors for this monthly AOGD meeting. Obstetrics, as we know, can sometimes be very challenging and test our clinical acumen. The common problems in pregnancy, which we seem very common and simple, can sometimes take an unexpected turns in form of either an unanticipated and a rare differential diagnosis, or it can be an unexpected serious adverse event like an anaphylaxis, or it can sometimes be a split-second decision like a perimortem cesarean section. So today we are going to present 3 such cases which we have managed under the theme of pregnancy complications, challenges tackled. And I invite Dr. Deepti to start the scientific deliberations of today's meeting. Dr. Deepti, please.
Thank you, madam. As you have introduced the theme of the meeting today, we are going to have 3 presentations. The first presentation is from Dr. Asmita, from Dr. Anjali Tempe's unit. And madam is senior most faculty of our department, and she is going to introduce the case to us about what was the pregnancy complication and how they tackled it. Madam Tempe.
Good evening, everybody. I take this opportunity to discuss an interesting case with you all. The vomiting in pregnancy is very frequently seen, and the treatment is also very common. However, this patient who was admitted with us needed a different kind of diagnosis and also needed a different management, which we very rarely see. So for discussing this case, she was admitted throughout with us for about 3-4 months, and then you will know the result, what it was. So I invite Dr. Vedika, who is SR in my unit, to discuss the case. And then later on, Dr. Devinder, who is a professor, who will be discussing the case and literature. So I invite Dr. Vedika to discuss the case. Vedika, please.
Good evening, everyone, and thank you, ma'am. I would be presenting a rare case of diaphragmatic hernia, which was managed in our unit. And ये वाला ना hernia is a defect within the diaphragm resulting from protrusion of abdominal contents into the thoracic cavity. It is majorly diagnosed in antenatally or in the first few years of life. Presentation during pregnancy is very rare and it has been scarcely described in literature. The incidence being 1 in 20,000 to 1 in 30,000. 1 in 20,000 to 1 in 30,000 as described by the Center for Disease Control 2019. So my patient, 23-year-old female, second gravida para 1L1 at 31 weeks period of gestation, presented to the gynae casualty.
Your slides are not moving.
Change your slides.
Please change your slides.
Change your
Ma'am,
slides.
are they moving? 23-year-old female, second gravida para 1L1 at 31 weeks period of gestation, presented to the gynae casualty with multiple episodes of vomiting, 12 to 15 per day for the past 3 days. This vomitus consisted of food particles and was associated with epigastric pain. It was non-bilious, not blood tinged, and she also had similar episode at around 28 weeks, which was managed conservatively. There was no history of any fever, cough, or chest pain, yellowish discoloration of skin, loose stools, or any blood transfusion. There were no bladder and bowel symptoms present or any outside food intake. There was no history of any leaking, bleeding per vaginum, or decreased fetal movement.
Just click on the slide once. Yes, ma'am.
Menstrual history, the patient last menstrual period was on 16th of December 2020, making her estimated date of delivery to be 23rd of September 2021 and period of gestation to be 31 weeks. Her previous menstrual cycles were regular. Obstetric history, she had a married life of 4 years. Her first pregnancy was 2.5 years back, where she delivered a female child by full-term normal vaginal delivery at Guru Tegh Bahadur Hospital with a birth weight of 300 grams. The baby is alive and healthy and immunized till age. There was no history of any similar complaints in the previous pregnancy. Her first and second trimester history were uneventful. In her third trimester at 28 weeks, she presented with similar complaints of vomiting and was managed by a local practitioner conservatively. And again at 31 weeks, she presented to us and was admitted for the same. The patient gives a history of stab injury during some robbery around 2 years back at home. However, no operative intervention was taken for this, and we do not have any records available for it. Her personal, family, and dietary history is uneventful. We examined the patient, and the patient was conscious, oriented to time, place, and person. She had normal gait and posture, and her BMI was 20.8 kg per meter square. On head-to-toe examination, a 3 by 1 centimeter transverse scar was seen below the left subcostal area. The remaining examination was unremarkable. Her vitals were recorded and were normal. Pulse rate was 88 beats per minute. Blood pressure was 120 by 72 millimeters of mercury, and respiratory rate was 16 per minute thoraco-abdominal. And temperature, she was afebrile, and her SpO2 was 99% on room air. Systemic examination no abnormality was detected. On her abdominal examination on inspection, abdomen was uniformly distended, umbilicus was central and everted, linea nigra and stria gravidarum were present, and all hernia sites were free. Local temperature was not raised, and her fundal height was calculated to be 30 weeks, corresponding to a symphysial fundal height of 30 centimeters and abdominal girth of 32 inches. And a single live fetus with cephalic presentation with an estimated birth weight of 2 kg was examined. So we came to a provisional diagnosis of 23-year-old female, second gravida para 1 L1 at 31 weeks period of gestation, with single live fetus in cephalic presentation, with the probable diagnosis of hyperemesis or starvation ketosis. We admitted the patient and ordered her complete blood count, liver function test, kidney function test, and also took a consultation from the surgery department, where we were advised in ultrasound whole abdomen, ultrasound hepatic vein, and the investigations were as follows. They were unremarkable, normal, but her liver function tests were deranged. And her dextrose charting was also coming slightly deranged with urine ketones positive. So we were managing the patient conservatively. The ultrasound whole abdomen was normal. There was no pathology detected in the liver or gallbladder, and the fetus was also fine. So we were considering a case of hyperemesis gravidarum, giving her IV fluids, injectable MSETs, Pantop with tablet doxynate, syrup sucralfate, and Digene, along with vital monitoring. But no improvement was observed. And then ultrasound hepatic vein was advised by the gastrosurgical department, and it was normal. And then our unit head, Dr. Anjali Tempe, she suspected a probable case of tuberculosis or subacute intestinal obstruction. And she ordered a chest X-ray and X-ray abdomen. And to our surprise, the radiologist gave us a report of diaphragmatic hernia. As we can see, there is elevation of the left dome of diaphragm with contralateral right mediastinal shift. Radio opacity can be seen in the left side with air fluid level, giving us a probable diagnosis of diaphragmatic hernia on the left hand side. And we immediately contacted the gastro-surgical department, GB Pant, and we were advised to get a chest CT tomography done for the same to confirm our diagnosis. And our diagnosis was confirmed. There was herniation of the stomach, jejunal loops, transverse colon, and passive atelectasis was also seen, but no ischemic intestinal signs were observed. And a joint decision was made by both the departments, the gastrosurgical and the obstetrical department of our unit, that since there are no evidence of ischemia, strangulation, and respiratory compromise, so we will conservatively manage this pregnancy till 34 weeks, till fetal maturity is attained. And then following which we will plan a hernial repair after 6 weeks. And at 34 weeks, a cesarean section was performed after giving a dexamethasone cover. And a male baby of 1670 grams was born. And the baby was admitted in the nursery because of low birth weight. And then thereafter, the patient was followed in the gastrointestinal surgery department.
Hello, good afternoon. I'm Devendra, and I'll be talking about the management and discussion about the screen sharing. No? This one. The diagnosis of hiatal hernia, she had a delivery, and after 6 weeks of that, she went to the.
Sir, please make it slideshow.
Yeah, it's on slideshow.
No, sir, we can't see you on slideshow.
It's here, Miss. I'll once again I will do that. Just do it.
Yes.
It's on slideshow now?
Yes, yes, sir.
Okay. So once we made the diagnosis of hiatal hernia, we referred the case to the GI surgery in GB Pant Hospital, and they did surgery. And just before seeing that surgery, I just want to show you the anatomy of diaphragm, and we can see there are 3 openings. One is for inferior vena cava, another one is for oesophagus, and then third one is for descending aorta. Normally there are three types of hernias which are commonly seen. One is on anterior side, parasternal Morgagni hernia. The other one is posterior side, where there is a agenesis of the septum that's actually leads to Bogdalek type of hernia. And the third one, which is commonly seen, is the oesophageal hiatus hernia, where the oesophagus is pulled up because of loss of periesophageal fat. And these are the common thing. And the fourth one, which we saw, was the traumatic, where there was a trauma in the diaphragm and the intestinal contents were shifted up. So these are the different varieties which you can actually understand that each one varies with the difference of the symptoms clinically. And the commonly what we see in the X-ray or in a if we do a contrast, then we can see the gastric content or intestinal content, sometimes liver inside the diaphragm, above the diaphragm. So this patient was diagnosed, confirmed, and then later on posted for a laparoscopy hernia repair. And this is the video of a hernia repair, where we can see a defect of approximately 2 to 3 centimeter size in the diaphragm, and the contents are pulled back into the abdomen after cutting the adhesions. Once the contents were pulled out, the defect was repaired with the mesh. It was stuck to the lower part of the diaphragm with the studs, and that's the way it was treated. So commonly these hernias are, this was a post-traumatic hernia. So it was repaired with the mesh. And if you look into the literature, exacerbation of maternal hiatus hernia is commonly reported, which can present as a hyperemesis gravidarum. And though these cases are not so common, very rare. So here in this presentation, we wanted to highlight one of the cause for the persistent or not treating to the routine management of hyperemesis. So keep diaphragmatic hernia in mind and plan the management. Thank you. Any questions? Okay. So I think I'll invite Dr. Deepti here for the next presentation. Thank you very much.
Our next presentation is also in keeping up with the theme of this today's meeting. And this presentation is from Dr. Y.M. Mala's unit. And I will call upon their resident, Dr. Uma, to present the case. And after that, faculty, Dr. Shakunti Agi, will be discussing the case.
शेयर करना है इसमें शेयर नहीं हो रहा शेयर
Everybody, myself Dr. Uma. I'll be discussing a case of anaphylaxis to iron sucrose. Yes, it is possible. Iron deficiency anemia has prevalence of almost 80% among pregnant females in India, and parenteral iron therapy in pregnancy is prescribed in severe iron deficiency anemia to avoid blood transfusions. In women where there is known compliance to oral iron, who are presenting late in third trimester of pregnancy, and malabsorptions. So today we share two cases of severe hypersensitivity reactions to iron sucrose because it is commonly used drug and such reactions are rare but potentially life-threatening. My case is a 22-year-old female who is gravida 3 para 2 live 2, 34 plus 3 weeks period of gestation, who was referred to LNH in view of severe anemia due to non-compliant to oral iron due to GI side effects. The patient was comfortable on admission, vitals were stable, severe pallor was present, and there were no signs and symptoms of failure. Rest of the systemic examination was normal. Per abdomen examination was corresponding to period of gestation. Investigations were done which confirmed severe iron deficiency anemia. Iron sucrose infusion was started 200 mg in 200 ml NS started slowly at the rate of 8 drops per minute for 5 minutes, and rest were completed over 30 minutes. Now, 10 minutes after completion of iron sucrose infusion, patient started having tingling sensation over feet and palm, which rapidly progressed to breathlessness, chest tightness, blurring of vision, and disorientation. While managing the case, we saw that patient was tachycardic, tachypneic, hypotensive, her SpO2 was 88% on room air, and on respiratory examination, bilateral air entry was diminished, bilateral wheeze and coarse crepes were present. We started oxygen supplementation with venturi mask, put the patient in left lateral, and injection phenaramine and hydrocort was given stat along with IV fluids. Nebulization was done with beta-2 agonist. But even after all this medical, there was no response and rapid deterioration of patient happened and patient went into cardiorespiratory arrest. Then we gave injection adrenaline 0.5 mg, 1 per 1000 dilution IM and started CPCR with bag and mask, ventilation and chest compressions. Patient was revived and became responsive, and after stabilization was shifted to ICU for further observation. In ICU, patient's vitals became better. IV fluid resuscitation, nebulization, and injection hydrocort was continued. After 5 hours, patient developed antepartum hemorrhage and went into preterm labor. Following short labor and assisted breech vaginal delivery, a baby was delivered with a very poor Apgar and shifted to NICU. Baby developed complications due to hypoxia and expired on postnatal day 5. Patient was monitored and shifted to OBS HTU and discharged under stable condition on 6th postnatal day. Now, my second case is similar case with the moderate anemia, where we gave iron sucrose to the patient. In this patient, after 10 minutes of completing iron sucrose infusion, again patient started having tingling sensation in both upper and lower limbs, followed by difficulty in breathing, swelling of lips, hoarseness of voice, and persistent vomiting. Again, the patient was tachycardic, tachypneic, and BP was on a lower side. SpO2 was 95% on room air. Bilateral chest had wheezes. Now, initial resuscitative measures were started and medicine and ICU call was done. Again, injection phenaramine and hydrocort was given and oxygen therapy was started, but patient did not respond to the above medical management. So we gave injection adrenaline 0.5 mg up to 1 to 1000 dilution IM. And there was no further deterioration. Patient was kept on nebulization with beta-2 agonist, stabilized, and was shifted to ICU for further observation. All the symptoms, including facial edema and voice changes, settled over 6 hours. So this patient was kept in ICU for 24 hours of observation and was shifted back to maternity ward on 2nd day and was discharged under stable condition within 5 days. Now, ma'am will discuss the management.
Final anaphylaxis, we should have skin or mucosal membrane manifestations, and one of the rest of the 3, which are respiratory compromise, reduced PP, or several GI symptoms. And even if the skin and mucous membrane features are absent, in case of hypotension, bronchospasm, laryngeal involvement, the patient will be defined as anaphylaxis. And how will we manage her? We'll remove the allergen, stay with the person, call for assistance, and mainstay is giving adrenaline 0.5 ml, 1:1000 dilution IM, anterolateral aspect of the thigh, and put the patient in recovery position with head low. Supportive management is required. Oxygen, give normal saline and glucagon for hypotension, monitor ECG, and if still recovery is not there, 2nd dose of IM adrenaline can be given. And if still there is no response, then IV adrenaline is required, but with strict ECG and pulse ox monitoring. What additional? For laryngeal edema, nebulization with adrenaline should be given, bronchodilators and corticosteroids for persistent wheezing. Now, it is very important that bronchodilators must not be used as first-line medication for anaphylaxis. And they do not prevent or relieve upper airway obstruction, neither hypotension or shock, nor steroids should be used as first-line medication, the way we used in our cases. And
Dr. Shagun, excuse me. Your slides are not moving.
should be used only
Slides
for
are not
and
moving.
skin manifestation. They are not to be used for anaphylaxis. Similarly, oral sedatives and promethazine should not be given. And if anaphylaxis
slides
is
are
very
not
severe and
moving.
refractory to
Can you
treatment,
hear me?
then we
Dr.
might have to
Shakun?
proceed for
Dr.
peri-arrest
Shakun,
section.
your
And Dr.
at least
And what all this anaphylactic it should have adrenaline 1 into 1 in 1,000 0.5 ml syringes, needles, defibrillators, BP cuff, IV access, and the IV fluids, and hand-free phone, if possible, should be available at that time to contact. Now, how to proceed further? Once we have acutely managed the patient, these should have immunology referral, and adverse incidents should be reported and form MOIC. And last but not the least, the pharmacovigilance program of India should be communicated to. And what is it? It is basically coordinating activities related to detection, assessment, and at the time.
Shakun, can you see your slides? Shakun, can you see your?
It's visible.
Yes, yes, it's visible now.
Is the screen visible?
Yes, yes.
Huh?
Yes,
Okay.
Shakun. Yes.
So basically, pharmacovigilance is detecting, collecting data regarding all the adverse effects, and then formulating policies according to it. And where do we report? So there is a website of Pharmacovigilance Program of India, and which states the email address, the helpline address, as well as there is a mobile app which we can download. This is the app which is available on the web store, app store, and this is a form which is available there, which can be electronically filled and submitted, which we all do. If we do not want to do this, we can download the PDF, which is available, fill it and send it to the, mail it to the website or the email ID. So what happens to all this data? So first of all, strict confidentiality is maintained. The causal assessment is carried out, and then the forms are analyzed by National Coordination Center, Pharmacovigilance Program of India. And finally, the data is analyzed and sent to Global Pharmacovigilance Database, which is managed by WHO Uppsala Monitoring Center in Sweden. What does the Pharmacovigilance Program in India do? So they periodically review all the various adverse reactions, and they bring out policies regarding prescription. So we went through the literature and we could find only one case report of anaphylaxis to iron sucrose in pregnancy. And this patient was a primary gravida, 7 months amenorrhea, who had severe anaphylactic reaction, and in spite of adrenaline, hydrocort, antihistaminics, ventilatory support, and inotropes, she could not be saved. So there was a letter to editor regarding this case report, and they suggested that it was Kunis syndrome. What is it? Which it says Kunis syndrome is coronary vasospasm because of anaphylaxis. Therefore, all these patients who have anaphylaxis should also be assessed for cardiac status by TROP-T and ECG, and maybe they require coronary vasodilators. This is a 2021 June report regarding management of hypersensitivity reactions to non-dextran iron in non-pregnant women, and they suggest that although the reported incidence of serious life-threatening anaphylaxis is pretty rare, 21 in 1 lakh. And because of this, the iron sucrose has favorable safety profile. But there are certain factors which we need to identify, which increase the risk of hypersensitivity reaction, such as previous reaction to IV iron, history of other drug allergies, severe asthma, severe respiratory or cardiac disease, and last but not the least, fast infusion rate. They suggested so slower infusion rate, especially in above high-risk cases, and slower than what are prescribed by the drug manufacturer. So the take-home message would be that we need to make the team aware of so that they keep high index of suspicion about the risk of anaphylaxis to iron sucrose, keep the emergency tray and crash cart ready. Our team should also be ready to manage any case of anaphylaxis. Reducing the initial infusion rate to almost 10% of prescribed rate might help. Eye injection adrenaline is the mainstay, and we should follow it up with evaluation of the patient by immunologist, reporting it to high authority, drugstore, and finally pharmacovigilance. Thanks for your patient hearing.
Shakun, there's only one thing that was important, was even 10 minutes, this reaction occurred 10 minutes after you had finished giving the whole transfusion, the whole
Yeah.
So, you know,
I will now call upon our third speaker, keeping with the theme of today's meeting, and she will be speaking on perimortem cesareans. I will call upon Dr. Nalini Pandey. She is Chief Medical Officer in our department, and she has a unique distinction of having post-graduation in obs-gynae as well as emergency medicine. And she has rendered yeoman service during our COVID pandemic to our patients, and she's the best person to present this case. Dr. Nalini Pandey.
Thank you, Deepti ma'am, for the nice words. I'll be just sharing my screen. Cesarean section. Let's see exactly whether we are doing it or not. The maternal cardiac arrest is a rare event. Estimated incidence is 1 in 30,000. The cardiac arrest in the pregnancy is a unique scenario, and it is a really challenging situation for an obstetrician.
Dr. Nalini,
sometimes referred to as resuscitative hysterotomy, which is actually a continuum of care of the resuscitation, which we have started, and it is a cesarean delivery in the setting of maternal cardiopulmonary arrest, primarily used to assist 38 years old woman, gravida 4 para 3 life 3 at 30 weeks of gestation with a known case of RHT, moderate MS, severe MR, admitted with NYHA class 3. She was very tachypnic at the time of presentation and is in the heart failure. ECG was sinus tachycardia, ABG was acute respiratory alkalosis, chest X-ray suggestive of pulmonary edema, and the echo was done, which shows RHT with severe MS, moderate MR, mild AR, and moderate TR with pulmonary hypertension and ejection fraction of. Am I audible?
Yes.
मैम उस पे तो दिखा रहा है 6 दिखा रहा है.
नहीं हमें आवाज आ रही है. We can hear you.
Sorry, ma'am, am I audible?
Nalini, you are audible. You are audible, yes. I don't know if you can hear me,
please.
but you are audible.
कुछ कह रही है, कुछ कह रही है.
Ma'am, please unmute yourself.
I'm unmuted. I'm not muted.
Approved. But after 15 days, that is at 32 weeks of gestation, patient had an acute episode of sudden onset of breathing difficulty, followed by shivering, and had an episode of a cardiac arrest. Just peri-arrest ECG shows S1 Q3 T3, which suggests that patient might have pulmonary embolism. The second case is 21 years old woman, gravida 4, abortion 3 at 36 plus 4 weeks. She is an unbooked patient, came in an emergency with a known case of ASD with pulmonary arterial hypertension, and she was NYHA grade 4. She is completely failure, had a pulmonary chest X-ray shows a bilateral peripheral fluffy opacities, And the CT shows the enlarged heart with a dilated right atria and right ventricle, with ostium secundum ASD of 25 millimeters with bidirectional shunt, severe pulmonary arterial hypertension. The final diagnosis was ASD with pulmonary arterial hypertension with left lobe pneumonia with type 2 respiratory failure. She was also managed in CCU, and immediately the emergency cesarean section was planned for her in view of maternal decompensation next morning. But before the patient could be shifted to the operation theater, she went into the tachyarrhythmias, the ventricular tachycardia, and the left side failure, and she suffered a cardiac arrest. So both of these are the cardiac arrest situations. Let's see how we have managed them. In both these cases, the maternal cardiac arrest team, the anesthetist, the obstetrician, and the pediatrician was activated, and the patient was made supine, left uterine displacement was done, and cardiopulmonary resuscitation was started. The decision for perimortem cesarean section was taken when there was no return of spontaneous circulation by 5 minutes of resuscitation. The PMCS was done concurrently by obstetrician with ongoing CPCI at the place of cardiac arrest with minimal initial requirement of scalpel. The abdomen was opened by a midline vertical incision, and the uterus was opened and the baby handed over to the pediatrician. The CPCR was continued while the surgery was taking place. The CPCR was given total of 12 cycles following the AHA ACLS protocol, but both the mothers could not be revived. The neonatal outcome of case 1 has a baby boy of 2010 grams who do not cry at birth, but Apgar was 157, and the baby was intubated for 10 days in nursery and then was on CPAP, and total NICU stay was 1 month. Presently, baby was doing well at 2 years of age. In case 2, the baby boy of 2230 grams was delivered, who was also not cried, but Apgar was 248. Baby intubated, resuscitated, and extubated after 48 hours, and the NICU stay of 8 days. And presently, the baby was doing well at 6 months of age. In both the cases, the husband and family members was explained about the cases and were given the psychological support. Now see the discussion about the perimortem cesarean section. Cardiac arrest in pregnancy can occur due to various conditions. The most common causes like trauma, pulmonary embolism, cardiac causes, sepsis, and eclampsia. The outcome primarily for the mother, but also for the fetus, depend upon the prompt and the effective resuscitation of the mother. And the resuscitation differs from the non-pregnant woman. Here I show this is the AHA 2020 guidelines, which shows the cardiac arrest algorithm. Whenever the mother has a cardiac arrest, that means there is no carotid pulse and no breathing in an unresponsive patient for 10 seconds. Then we start a CPCR according to an AHA protocol. While starting the CPCR, always there should be a code which assembles the maternal cardiac arrest team, and there is a separate maneuvers for obstetrical intervention, like providing the continuous lateral uterine displacement, detach the fetal monitor, and prepare for perimortem cesarean section if there is no ROSC, that means reversal of spontaneous circulation in 5 minutes. Then we have to do that, while a neonatal team should also be ready for that. Various case reports and studies have shown its value in aiding the maternal resuscitation. Even though recommended by various international organizations, it is still performed rarely due to the lack of the awareness and hesitancy. Prior to 1986, only 188 cases were reported. Between 1986 to 2004, only 38 additional cases. And the second review between 1980 to 2010 shows that there is 94 cases, which was overlapped with the first review. Even when performed, the decision to the delivery interval, it is seen that it compromises the outcome of both the mother and the baby. So time is very important in perimortem cesarean section, and every second counts. That is why we are discussing here. The concept was introduced by Katz et al. In 1986. Initially, it was focused on infant survival and found that 69% of the infants survive when it is done within 5 minutes. However, when we explored, Katz et al. Further explored the maternal outcome, they found that hypoxic brain injury only occurred if PMCS was performed after 6 minutes. So that is why there is a rationale of 4 to 6 minutes, because after that there is an irreversible brain damage. However, it is seen that if the baby was also taken out within 5 minutes, there is very much chances of survival of the baby as seen in our cases, and it is a level 4 evidence. Since after these publications, in 1992, the AHA guidelines for perimortem cesarean section has become a standard of care. The maternal survival following the perimortem cesarean section varies greatly among the different studies, ranging between 34 to 54%. The primary goal is the improvement of maternal resuscitation. So ongoing maternal resuscitation, we have to do that. It basically, during resuscitation, the gravid uterus reduces the venous return and the cardiac output due to aortocaval compression, and delivery of fetus and placenta by PMCS reduces the oxygenation consumption, improves the venous return and cardiac output, and facilitates the chest compression and makes the ventilation easy, and improves the respiratory mechanics as diaphragm is lowered after the procedure. When, where, and how should we do that? In a woman over 20 weeks, if there is no reversal of spontaneous circulation, to correctly perform CPCR within 5 minutes of maternal arrest. PMCS should be undertaken to assist the maternal resuscitation, even if the fetus is dead. And there is no need even to check the viability before PMCS. PMCS should not be delayed by moving the woman. It should be performed where the collapse has occurred and the resuscitation is taking place. PMCS can be performed anywhere with only a scalpel being the essential requirement. The operator should be an obstetrician or a surgeon. Equipment, apart from the maternal resuscitation kit, we should have a cesarean kit, number 10 scalpel, hemostat, large scissor, gauge sponges, and the baby resuscitation instrument should also be there. Maternal cardiac arrest team activation is required whenever the CPCR starts, and it involves the obstetrician, the anesthetist, the neonatologist, intensivist, and the ER, ICU, obstetrician, and NICU trained nursing staff. Preparation to ensure that there is no delay. PMCS, when indicated, the equipment necessary should be immediately available on the resuscitation trolley. We have made the protocols to keep one PMCS tray ready in HDU every time. So for these cases, the first case was already in HDU, but the second case was in CCU. So we have emergently, one of our PG have taken that tray. Till then, the senior resident have done the cesarean by using a scalpel from the central venous cut down tray. It is said that when there is no circulation, the blood loss is minimal, so no anesthesia is required. Basic aseptic precautions such as pouring the antiseptic solution over the woman's abdomen prior to incision may be considered, and then just use a scalpel and an umbilical cord clamp if present. And in the absence of specific tray, only a scalpel can be enough to cut open the abdomen and the uterus. How to do that? Make a vertical incision from xiphoid to the pubis using a scalpel, ideally number 10 blade. Cut through the subcutaneous tissue to get the peritoneal wall. Use the fingers to bluntly dissect the peritoneum. Cut through the peritoneum vertically, deliver the uterus, and then cut the lower half of the uterus vertically to avoid the placenta and extend the incision upwards. Deliver the baby, hand it over to pediatrician, clamp and cut the umbilical cord, and place the packing towels in the open uterus and abdomen. Further closure of the incision depends upon the maternal response to the resuscitation efforts. ACLA should be continued on the mother until the ROSC is achieved. If the resuscitation is successful, then subsequent closure should be done by transferring the patient to the operating room, as well as anesthesia, sedation, control hemorrhage by completing the procedure. Also, take a precautions of antibiotic prophylaxis to be given. Now coming to the legal aspect, the doctrine of best interest of the patient would also apply to conduct of this procedure to be carried out without consent. Despite being an invasive procedure in an emergency setting, perimortem cesarean section should not be delayed in an attempt to obtain the consent. Most series of PMCS have shown a favorable result with delivery occurring less than 5 minutes from the time of maternal death. AHA 2020 has recommended that delivery within 5 minutes of arrest should be done. Thus, providers of maternal care should be aware about the basic knowledge concerning the maternal cardiac arrest and PMCS. Also, AHA and the maternal collapse, RCOG, have recommended for having the training and support for resuscitation skills. Thus, hereby I conclude that PMCS is rarely required, but if performed in a timely manner, it may improve the maternal and neonatal outcome. Since the awareness of this procedure is not universal, training and evidence-based guidelines should be in place. All centers must be equipped, and more drills are required for dealing with the pregnant for the resuscitative hysterectomy. Thank you for patience here. Now I just thanks Dr. Deepti to further.
Slide कैसे हटाएं? Stop share. I have just one thing to say. When this topic we were reading and going through, the point which came to my mind was the medical legal aspects. So what interesting fact I read was that in America, several such procedures have been done and there have been no litigation. Rather, there have been two litigation in the cases where this procedure was not done. So I think we should shed our fears about medical legal indications, and wherever we feel difference can be made, this should be attempted. As exemplified these two cases where though the mother could not be saved, but the two babies are thriving well. With this, I open the meeting for any discussions and any questions from the judges.
There is a question in the chat box about can perimortem cesarean be in private setup? What is the requirement for consent? Could you hear me?
Dr. Gauri, we can't hear you.
But I'm unmuted. I'm not mute.
Can you hear me? Can you hear me now?
Yes, we can hear you.
But they can't hear us, is it?
Dr. Devender, I have a question from you.
Yeah.
Dr. Gauri was asking, can this, perimortem cesarean be done in a private setup? Gauri, that was your question?
No, this is from someone in the audience.
Okay,
And
yeah.
what are the requirements for consent?
No, ma'am, no consent. As Dr. Nalini has already explained, that consent is not mandatory if it is really a perimortem, just to save the baby as a last effort. Otherwise, if you will be wasting time to obtain the consent.
Dr. Devendra, my question is to you. You presented your very beautiful case, but you did not do a literature search, how many cases you come across, literature. I mean, what was their outcome? I mean, yours was a alone case.
No, actually, there were few cases, but the number was not even in 2 digits. It was a rare condition, and in fact, what happened is this: that in this case, the same surgery can be done along with the cesarean. But in our case, this was an incidental finding. We didn't think of a diaphragmatic hernia as a part, means the cause for a hyperemesis. It was incidental because our unit head, Dr. Anjali Tempe, thought that she is having tuberculosis associated some adhesions, and that may be the cause, and she wanted a chest X-ray. And then we had a discussion, and our GI consultant, they said that.
Devender,
Yes,
let me answer this question.
Okay,
This patient actually, Dr. Manju, was treated for 7 days with all medicine consultation.
All that I've heard. What I'm saying is, it would have been great if you had put, literature search, along with this.
Yeah, that I agree. They cut it short because of the time, actually. But there are 74 cases reported. And in pregnancy, what happens, I let the listeners also know some information they should get. What happens is diaphragmatic hernia recedes once the uterus goes down. So conservative treatment is advised when the patient is pregnant. That is why the diagnosis is also not clear. They are not clear about diagnosis unless X-ray chest or CT shows so this was in this case detected. There might be some few cases who go unreported and undiagnosed. This is what I want to highlight here, that according to GI surgeons also, the contents slide down and up and down, and they are not actually, there are no adhesions but in this case, there were adhesions at the hiatus, which we saw. I attended the surgery also. It was my interest. And it was very, very surprising that no adhesions were formed in the chest. Chest also can have adhesions. What can happen is finally the hernia remains there and the patient really has a problem. But in this case, it was sliding down and up and down and up and down. And that is why patient could have some relief sometimes and no relief. And this stab wala story is afterthought. It was not diagnosed earlier. Nobody thought about it. Na surgeons, na physicians, na hum logon ne. When the X-ray showed, the radiologist diagnosed it. That was the interesting part of it. because X-ray abdomen showed the herniated stomach and herniated large bowel and small bowel. Everything was inside. And the left lung was collapsed. And this also did not produce any symptoms in the patient, which I asked about. So they said that, madam, this slides up and down. And that is why the collapse also doesn't give much of symptoms. However, interesting part of the story in the surgery also is when they do this operation, the anesthetist actually expand only the right lung and left lung is collapsed iatrogenically while doing the surgery. So they actually had a collapsed lung, which I saw, and whole contents in the chest coming up and down, and they were freely moving. I saw it myself. So I thought it was very interesting. And their adhesions were very minimal. And that is why patient did not have, except that she had a malnutrition because she just could not digest anything. So she was totally on IV for 3 weeks. And 3 weeks later, we did a cesarean. So 31 to 34 weeks, she was getting only TPN and Hermin and multivitamins and IV fluids. She could not tolerate anything almost. And still they did for conservative treatment, thinking that post delivery, it might go down on its own. However, Dr. Nag from GB Pant Hospital operated upon her. There was a thought that cesarean and the hernia should be done at the same sitting. However, they are not very keen. They wanted to see, they came, one senior resident came and decided against doing surgery at the same time. However, they said 6 weeks later, if this remains, we will do. And patient was symptomatically better after delivery because the uterus went down, but not totally. And that is why 6 weeks later, they evaluated her again and did surgery. Not always surgical option is done. Not all cases require surgery.
My last question is to Dr. Vaimala. These patients, they gave, iron sucrose. I just want to know, is somebody from their case present over here?
Yes, they are
Yeah. So, why was, iron sucrose given when we know iron, barium carboxymaltose is present and it causes less reaction? Why was iron sucrose selected to be given? I mean, do you routinely give? We don't give iron sucrose.
FCM is not FDA approved in pregnancy.
Oh, you can give it after 12 weeks. You can give it after 12 weeks.
No, patient was after 12 weeks of after delivery.
Once patient has finished 12 weeks of pregnancy, one can give iron for barium carboxymaltose.
Ma'am, it is not our departmental protocol to give FCM.
I think you should modify your protocol.
We are giving only iron.
Foxy also recommends it. Why is iron sucrose given?
Our unit protocol.
Manju, this iron reactions with iron sucrose are very rare.
No. They are much more than the iron barium carboxymaltose. One thing. Secondly, whenever any intravenous iron is given, patient is asked to stop oral iron for 2 days before you give it. So was that done or no?
No, that is done. That is done. And iron sucrose has been given for now a long time, and this is very rare that we this type of reaction. So we just wanted to make everyone alert that even 10 minutes after stopping the drug, don't just walk away from the patient. They can have that reaction. That was the idea because it's still being given in a large number of places.
Yes, Dr. Gauri,
Yes,
I agree with you.
Can I ask?
Like that. Planted up in the ICU. So were the batches similar for the injections that were administered to the patient? Was it the same batch?
No, the batches were returned.
Of the injection?
The batch which caused the reaction was returned, and this was a different batch.
Okay, thank you.
So, can you hear me?
Yes, we can hear you.
Dr. Deepti, Dr. Bhaskar, yeah, all the cases were good. I congratulate PEMC department. For the first case, I would like to know that if it was diagnosed antenatally, definitely you would have preferred the surgery, that is corrective surgery along with cesarean section. I hope it was diagnosed after the procedure, after cesarean section.
No, it was diagnosed before the cesarean, and with the consultation, we have planned it after that. Purposely, it was planned after the surgery, after the delivery.
Taru's question, Taru, can you repeat? Antenatally, it was not diagnosed and she had a normal delivery earlier, and nobody thought about this stabbing as a cause of diaphragmatic hernia. Only when diaphragmatic hernia was diagnosed, The
It must
stab
have
ka
been, yeah, ma'am, it
iski-
must have been diagnosed post-cesarean, no, in the post-operative period.
What?
No,
What?
no, it was diagnosed
What?
during this pregnancy.
Diaphragmatic hernia.
Diaphragmatic hernia was at 32 weeks we had diagnosed. 1 week it took. A medicine department treated her as GERD. Medicine department sent it to surgery. Surgery said it is
No, ma'am,
okay.
it is okay. But
So-
why it was not repaired at the time of cesarean? You had given a vertical incision, no?
Yeah.
So it could have been approached at that time also, no? With the surgeons could have managed at that time. Why to
Yes,
unnecessarily?
yes, you are right. But septicemia, anything when you do during the antepartum and postpartum period, septicemia is a likely always.
No, Taru, when you are putting a mesh, I don't think anybody will do it at the time of cesarean. So I fully agree with Dr.
Yes.
Temple.
Ma'am, there are reports in the literature where they have repaired together at the time of cesarean delivery. They have repaired the diaphragmatic hernia with the using Prolene figure of 8 sutures.
Okay, this is another thing. This girl is telling me from behind that the patient also refused surgery at the same time.
This
She
was
said
actually- this was
dogmatically
discussed with
that
the-
we don't want surgery right now. We will see. This is the girl is saying from behind that yes, this is true because surgeons and the patient should decide. No, so patient also refused. However, you are right. We can do, but mesh. I asked one interesting thing was that mesh is not covered. For all of us to know, mesh is intraperitoneal and on the diaphragm, but it is not covered. So this was also a knowledge to me that it can remain on the diaphragm like that. So I asked the GI surgeons, he said that this is always like that.
And
Okay, ma'am. Thank you. Yeah.
Dr. Taru, actually commonly the commonest hernia, diaphragmatic hernia is hiatal hernia through the oesophagus, the opening because of loss of periesophageal fat. The commonest thing. This traumatic was a very rare, hardly any. Madam is saying that 74 instances, that's actually most of them are hiatal hernia.
Yes, sir. Yes, sir. And in pregnancy, because of the increased intra-abdominal pressure, it further aggravates, and the vomiting further aggravates, increasing intra-abdominal pressure. So
it was
could
in
be
fact when she sustained the trauma, most probably there was a trivial injury to the diaphragm which was
the
missed,
diaphragm.
and that became aggravated and during this pregnancy.
Dr. Taru, there are two things. One is hiatus hernia, where the fundus of the stomach only herniates, but hiatus hernia is different from diaphragmatic hernia. And diaphragmatic hernia, every content, small intestines, even the spleen also sometimes goes in.
Yes, ma'am. It can
So
go through.
that is why the patient has a lot of problems eating. And it would go down. How she survived is it would go down, obviously. That is why.
Ma'am, that's why the typical symptom is that patient complains of vomiting more in lying down position. And just after foods, the symptoms are more in patients with diaphragmatic hernia, but it was a very rare case.
Yeah.
And in fact, very well managed. Yeah. Coming to case 2, although the reactions to IV iron sucrose, which we commonly use for antenatal patients, is a very safe, but it was a very rare severe anaphylactic reaction and well managed. My question is that in both the cases, you had transfused your 200 milligrams of IV iron sucrose, no? Completely. It was not at the start of infusion. No. So usually I think anaphylaxis, because it is because of the complement activation related triggered by iron nanoparticles, which is said in the literature, it should usually occur within the first 30 minutes. So how do you explain anaphylaxis as a cause of severe hypersensitivity reaction? That is after completion of your 30 minutes infusion, and in fact after 20 minutes or so. So how do you explain that thing?
Shakun, we had discussed that when we were, yeah.
The literature says the anaphylaxis can be at the end of 30 minutes or even after later also. So they suggest monitoring of these patients or very close monitoring even after transfusion. These kind of reactions can occur even infusions, not transfusion. So it is not always immediate. And even in the definition, it says that the reaction can take place few hours also after the contact. And anaphylaxis is something which cannot be predicted. And once the reaction starts, we never know how severe it can be. And the time period is also not defined. It can occur immediately, it can occur after 30 minutes, or even after. So in one patient, it happened 10 minutes after the finishing of the infusion. So almost 40 minutes. In the second patient, that was in front of me. The infusion had just finished and the patient started complaining of tingling. The whole face got swollen. Patient became so tachypnic and her voice changed. And I also I panicked because we'd seen that very severe reaction, the other patient also. So it is not always
managed emergencies. Huh? It was a very timely diagnosis and a well managed. Now, coming to the third case, the important thing is that the decision to delivery interval, it should not be more than 5 minutes. Basically, it should not be more than 4 minutes.
Yes, ma'am. BHA 2020 have revised it to 5 minutes.
Because every... Okay. It's okay, fine.
Thank you, Dr. Asmita and your team for a beautiful presentation of these rare cases. And thank you all the judges for today's such an interactive session. Now I will invite Dr. Rekha to proceed with the quiz session.
Ma'am, we don't have quiz this time.
Okay.
So this brings us
I
to
did
the end of the session. I would like to thank all the AOGD members, especially the senior members who are logged in. I could see Dr. Kamal Bakshi ma'am, Dr. Sunita Mittal ma'am, Dr. Trivedi ma'am. I thank you for being here, and your presence gives us encouragement. I thank the faculty of Maulana Azad Medical College for the excellent case selection. The cases were really of good academic importance, and I especially congratulate you to finish it on time in spite of having all those technical problems. I thank the judges, Dr. Manju Khimani ma'am, Dr. Taru Gupta ma'am, and Dr. Rima Kumar ma'am for accepting our invitation and for excellent case discussion. I also want to thank Dr. Renu for organizing today's clinical meeting. And I also thank our academic partner MCure for this event, and want to thank Mr. Shivam at the backend team for all the technical help. And this brings us to the end of today's monthly clinical meeting. And we'll see you in the next meeting on 31st December at Gangaram Hospital.
Thank you everyone for joining. Hello, Dr. Bakshi. You
Hello.
have attended
Fine.
both the meetings today. Executive as well as monthly. That's very nice.
Thank you. Everything very nice. Yeah, I attended the second part from the beginning, and the first one I didn't attend completely.
Anji Madam, Dr. Bakshi.
Manika, as far as the executive was concerned, I attended only a small part of it. But as far as the clinical meeting is concerned, I attended completely. And I was thoroughly impressed by the cases. And the best part is the discussion. And it is the discussion which brings the beauty. It was a lovely thing. I really enjoyed.
And it is wonderful to see you, ma'am. It's wonderful to have you with us.
Yes, ma'am. Good evening, ma'am. Pleasure to see you.
Good evening. Good
And
evening.
Dr. Sunita Mittal was also there. So, ma'am, good evening.
Ma'am is still there.
Yes, she's there.
Ajla, who will attend the meeting on 31st December?
Very interesting presentations, very good cases, and really lively discussion.
31st December should be a holiday. No, Manju?
Who will be attending? Nobody will attend. Make it earlier or after, please.
Yeah.
Let Dr. Bakshi and Dr. Mittal decide that 31st December working or holiday.
I know. We can do it in January.
Chalo, then we will do it again in first Friday of January.
Perfect. Perfect.
That's a good idea.
Good idea. That's a good idea.
Yes.
I think with digital meetings, AOGD attendance is definitely improved.
Yes.
Yeah. Many people who could not travel a distance also join in. So that's very good. But today's presentations were very good, really good.
Yes. And good presentation of this thing, perimortem, cesarean, and that anaphylactic reaction. They really reviewed the literature.
Not only review, these both are very rare conditions, and still they have had cases. So that is something.
I'm very happy that I'm seeing the seniors. I wonder how many postgraduates and registrars are here, because such beautiful cases, it's a good learning experience for the young students also. I'm sure Achla Batra or Asmita might be knowing where the younger generation is.
On strike, madam.
Strike. A good one.
They are actually on strike, madam. They are actually on.
Perimortem cesarean is such a dicey thing and puts you under so much of stress. We had a woman who was COVID positive very recently. She was first on CPAP, then they wanted to shift her to ventilator. So they said deliver. She was 32 weeks. But before she could be put on ventilator, she died, of course. This thing, and then she had, of course, baby is still in the NICU, but we really don't know. They put you so much of stress on you.
Correct, correct.
I think I'll take leave, ma'am.
Okay. Very
Bye-bye.
Manju, it was nice. Lovely discussion.
Okay, thank you. Thank you for everyone, all seniors. It was really a pleasure and great blessing to the department. Thank you so much for being here with us. And Dr. Batra, Dr. Tripathi are with me physically, so I give them special thanks for their presence here. Thank you.
Thank you.
Okay, bye-bye.
Bye, everybody.
Congratulations to Asmita. Very well done.